Welcome to the Learning Lab. My name is Roman Garcia. What we're going to be discussing today is, like usual, we're going to be discussing a case. I'm going to be presenting some information, some insight as to procedures and protocols that we use in our clinics in order to define degenerative condition. We've been concentrating lately on these last few videos on the knees, and we're going to continue as such. But recently we've been getting some feedback on our videos, and most of it is good, but some of it is bad, and some of it is critical of how we do the videos and some of the paraphernalias that we use in our videos. For example, we've been getting some critiques upon the pipe that I use. So for what I want to do is I want to explain why I have this pipe and why I use this pipe and what function this pipe plays in our video or in the general scheme of things when it comes to what we are trying to do with these videos, which is basically to educate and to demonstrate that there are right ways and wrong ways on how to perform physical examinations of joints of the human body. Now, the reason that I use this pipe in the videos is that, pure and simple, it makes me think better. It's a apparatus. It's an object that I use in order to give me a little bit more peace of mind and make me focus more on the observations or patterns that exist in my environment that I can use in order to create a gateway to greater insight, which is basically what I try to do with these videos. I'm providing information or my experience on how patterns dictate or patterns demonstrate certain physical rules and physical laws that the human body use or are exposed to in both health and disease. So the pipe is nothing more and nothing less than just a mechanism that I use in order to allow me to think. Now that we're on the topic of thinking, one of the problems with the medical profession, when you go and you share your pain with a medical professional, a doctor, a physical therapist, chiropractor, orthopod, neurosurgeon, neurologist, it doesn't matter what discipline they reside in. One of the problems that exists in our medical establishment is the inability to think. Right now, the way that medicine is being practiced in a fashion where thinking is not being done at a level where insight can be gained from each patient encounter. Doctors nowadays, they're basically diagnosing patients, and diagnosing patients or coming up with diagnoses based on very general information or very general patterns that they experience on a daily basis, without really using individual patients as a model for individual circumstances, which sometimes or all the times express themselves in ways that are unique only to one patient and not another. So in other words, what doctors are doing now is they're combining all diagnostic under one umbrella. So everybody that comes with knee pains, the normal protocol is that an X-ray or an MRI is done. The report comes back or the X-ray is seen, and the typical response of the doctor is that you got arthritis. And sometimes they'll qualify it by saying you've got bone on bone, or they'll use very general terminology, which the patient has to accept because the patient doesn't know any better. But the truth is, as if you've been seeing these videos, is that there's a lot of subtleties, a lot of differences that exist in how a degenerative condition materializes itself in the joint. And only unless you're able to think on an individual basis, patient per patient per patient, will you be able to define the degenerative pattern, the degenerative characteristic of that unique patient. And only in that way can you implement a model or a protocol that's specific to that particular patient. That's not how it's being done now. It's being done in a very categorical way, where everybody's getting the same diagnosis. It's really laziness on part of the medical practitioner. And believe me, there's a lot of laziness out there when it comes to evaluating and examining patients. Doctors nowadays, they do not have the time, and worse, they do not have the will really to evaluate patients on a specific individual basis. So what I want to do today is I want to share with you a particular case that we saw in the clinic not too long ago, and I'm going to go step by step physically on how the examination is done. But what I want to do is I'm going to share with you first the clinical examination. This was done prior to any x-ray or any MRI or any kind of diagnostic test that was available or that was yet to be done. So you can get an idea what an individual who thinks and has been able to recognize pattern is able to predict when a diagnostic test is accomplished. So basically what I'm going to do is I'm going to share first the clinical data that was retrieved on the clinical examination alone. This is somebody who is able to think, who thinks on an individual basis and has been able to recognize patterns. Okay, so this is basically a patient that came to us not too long ago. She was a female. You can come to me, Carlos. She was a female. She was in her 40s, 40 years old. She was about in her mid-40s. She wasn't obese. She wasn't in overt pain. She really didn't report pain. Her symptoms were primarily a concern. She was concerned about her knees because she started to experience pain with certain activities which before were not producing any pain, such as squatting or going up and down stairs. That was her primary concern. Aside from that, this patient had absolutely no pain. Sleeping, prolonged sitting, standing, she had no pain. She only had pain when she went into deep squats and going up and down stairs. So this made her very concerned about the status of her knee. So she went and she sought an orthopod's opinion on what was happening. When she went to the orthopod immediately didn't do a physical examination. He immediately sent her to an MRI. When the MRI results came back, and it detected a complete tear of the ACL on the left knee and a partial tear on the right knee. So obviously this drove her to worry. And she was very worried about that diagnosis because the orthopod recommended an ACL reconstruction of the left ACL, which had her and created tremendous amounts of stress in her life. So when she left the orthopod, a couple of days later, she contacted us and she came over to our clinic where I examined her. I did the initial examination, and this is the examination right here. So I'm going to share with you what the findings were, and what I did is just to simplify the process. These are the main data points that was acquired on this physical examination. This patient, the ACL tear that the MRI supposedly, allegedly discovered was on the left knee. The right knee had the partial tear. She was experiencing more pain on her left knee than she did on her right knee. So the physical examination revealed this. It revealed that the range of motion, the biomechanics of the left knee was normal. Just from visual examination alone, my conclusion was that this patient was experiencing knock knee in the left knee. Just visual examination. Visual examination to determine knock knee or bowing is not 100% accurate. For that, you need an x-ray, and I'll show you the x-rays in a little while. But just from visual observation, it appeared she was in knock knee. Most women are knock knee. So I wrote it down as structural valgus because it looked as it was structural valgus. She was knocking. She had congestion, or the medial side of the knee I was able to detect and palpate scarring over the joint space width, over the medial compartment. So she had congestion and effusion over the medial compartment. And when I tested the integrity of the ACL, it did reveal that there was instability. There was a grade 1 instability. It didn't, clinically, it didn't test as if it was completely torn. So I disagree with the MRI, which she brought with her. She was grade 1 ACL unstable, but it wasn't a complete tear. Now, on the right knee, this is the findings. Her biomechanics were compromised. She had negative 3 degrees of extension. In a little while, I'm going to show you physically how I determined that, though we've done videos on this before. She was also valgus. She had valgus on the right knee, which in my interpretation was of the structural kind. But she had congestion and infusion on the right lateral compartment. On the outside part of the knee, on the left knee, she had it on the right. So those were the physical examination. You can come to me now, Carl. So basically, after the clinical examination, I concluded, based on the pattern that the clinical examination revealed, that the right knee was the one that had more structural changes than the one that she was concerned with, and the one that had the greater instability, the ACL instability, which was on the left. The clinical examination, at that moment, the hypothesis was that the right knee was under a degenerative condition. I had not yet seen the x-rays, and I'm going to show you the x-rays in a little while. Now, this is the x-rays, and I'm going to show it to you now. Now, remember, Carlos, you can come to me now. Remember, the clinical examination gives me about 90% of what I need to know. The x-rays and the biometrics, these graphs that I do on the x-rays, give me the other 10%, which pretty much gives me a good idea of what the reality is of the knee. It's not perfect. It's an evolving program. It's an evolving protocol of diagnosing and of objectifying the knee. But it's a heck of a lot better than anything that exists out there right now, where diagnoses are made by very generic motions of the knee, if the physician even touches the patient's body, or primarily by diagnostic tests. So immediately, the clinical examination did not jive with the MRI. This patient had an ideology, an idea what was going on with her knee that her clinical results did not jive with. So immediately, obviously, there was a disconnect between the clinical examination and the MRI. And I'm going to show you what the x-rays look like. This is the x-ray right here. This is the right, this is the left. The clinical examination expressed itself as more concerned towards the right knee than the left. And the x-rays kind of confirmed that. So the clinical examination jives with the x-ray. This is the right knee, this is the left knee. You can see that the joint space width is more compromised on the right than it is on the left. Now, mind you, it's very subtle, but it's there. So the right knee, just on x-ray, jives with the clinical examination. This tells you how sensitive a clinical examination can be when it's done when the examiner is under a thinking mode. So you can see that there's less joint space width on the right knee than there is on the left. Now, another telling sign here, and again, this is a copy of the x-rays, but the x-rays, the subtleties the differences were greater. But the right bone tissue is slightly wider than it is on the left. This tells you that the resilience, the bioresilience of this right knee was more compromised than the left was. This patient, this knee was either in a greater degenerative condition, which I do believe it was, or is her primary weight-bearing leg. She's primarily weight-bearing on this right lower extremity. Thus, she's putting more load on this right knee. Thus, it's under a greater degenerative strain. Again, you see here. Now, the interesting thing is that you can tell that the x-rays pretty much jive also with her symptoms. This patient was not symptomatic in a way where a knee that's under a greater degenerative strain, the symptoms were very different, would be more involved. This patient had no pain when she was prolonged standing. She was able to sleep, no pains at night, etc. Now, you can see here, remember we discussed in the last video the Parrot Beak deformity. You can see here, there's no Parrot Beak deformity. What this tells me is that this knee has not been under duress for a prolonged period of time, which jives with her symptoms, because her symptoms were only of about a 3 or 4 month nature. It wasn't that long. Again, just to remind you what a Parrot Beak deformity looks like. This is a Parrot Beak deformity. This patient has lost all the fractal elements that make up a normal tibial plateau. It's very smooth. In biology, smooth surfaces, especially close to the joints, is not a good sign. So in this knee, this is the classic Parrot Beak deformity. Very smooth. It's a smooth line straight up here, especially here. This is what gives it the Parrot Beak deformity. You can see in this knee, there's no Parrot Beak deformity. Look at this jagged. This is normal. Jagged edges here. Very different. You see? This is a fractal structure. It's not smooth as this is. So there's no Parrot Beak deformity. Obviously, you can see that these knees are tremendously involved. This is another case, but you see this smooth line. Smooth line. Parrot Beak deformity. This patient had no Parrot Beak deformity, so again, negative on the Parrot Beak deformity. Now, these are the biometrics. You can see here, these are the vector lines. Again, remember what I said, visually, this patient visually appeared as if she was in knock knee. The right knee, at this point, I'm convinced that the right knee is the primary concern. So this right knee is going to be treated differently than this left knee is. This left knee biomechanically is not, there's no changes in it. It's a relatively normal joint. So again, and the tissues itself are not under duress as much as it is on the right. Here you can see clear that this white bone right over here, this bone right here is wider than it is over here. This is more translucent. That means that this bone here has lost bioresilience. Again, and then these are the metrics. The left knee is definitely in valgus or knock knee. The right one, which we know up to this point that is under a greater degenerative strain, is in neutral. The patterns that I've observed is I would make an educated guess, a thinking guess, that this patient, just like most women, it's natural for her to be in a knocking structure. So this left knee, this valgus in this left knee, this is normal for her. This is not an abnormality. But if you come over here, you see this vector line right over here. It's right down the middle. So she's gone from normal valgus and she's heading the other way. This knee is literally going into bowing. This is not normal for her. This is not natural for her. If this continues, this right knee will continue to degenerate at a faster rate than this left one is. Than this left one does. Now you can see here the magnitude triangles over here. They're pretty much the same. Since she is a natural not near or valgus, you always expect the lateral magnitude triangle to be larger than the medial magnitude triangle. And again, this is what we see here with these biometrics. The biometrics, the mathematics, pretty much substantiates the thinking examination that was done of this patient. So here we have mathematical support of the clinical examination. Again, this clinical examination was done before I saw these x-rays. I always do it like that because I don't want to be biased. With my clinical examination, it's important that the individual, the examiner who's doing the examination, is open-minded and is not under any kind of bias whatsoever, which is one of the problems that exist in our medical community when it comes to orthopedic cases. Most physicians, all physicians, are biased already. So they give extremely general diagnoses, and that is a big problem. And that's why I use the pipe, because it makes me think. Now you can make fun of it, some people are making fun of it, but that's fine, because I prefer to give an exact examination and be a thinking person versus somebody who's just operating in a root manner. Again, now what I want to do is I just want to go real quickly with the physical examination on how it's done. We've done this before, but I just want to go through it again with my assistant, Ana. So I just want to introduce Ana to the general public, and she has just something to say.
Hola a todo el mundo, a todos los que nos quieren y a los que no nos quieren, nosotros los amamos.
Okay, alrighty. That's what she wanted to say. So basically what I want to do now is I want to do how the examination is done on a typical knee examination when a patient comes to our facility. Which, by the way, if you're in South Florida, you're visiting, you have issues, knee issues, hip issues, low back issues, and you're in the South Florida area, we always leave our phone number on these videos. If you're interested in coming and getting the best physical examination you can have in your whole life, you contact me. And I'll tell you where you can go so you can get exposed, or I can examine you, and I'll tell you exactly what's going on with whatever joint in your body you have problems with. Okay, so if you're in the South Florida area, feel free to give me a call and you can visit the facility. And I'll give you an examination and I'll tell you exactly what's going on with your body. Okay, but for right now, what I'm going to do is I'm going to show you how the physical examination is done. The first thing the patient does is she sits here. This is typical. This is typical. Sometimes I use the word joint whisper. Because in essence, that's what I am. I can tell when a joint is under duress and when it's not in duress. I can tell what areas it's under duress. I can tell what region of the joint is involved. All this comes when you think. If you don't think, you don't know nothing. You may have a license, but you don't know nothing. And you're not giving the best service possible. The patient is leaving the facility with false ideas, a false ideology. They don't know the treatment program is not specific to the patient. So basically what I do first is I palpate the joint lines. I try to detect if there's any kind of congestion, any kind of thickness underneath my fingers. In the patient that we went through, there was in the left knee, she had congestion on the inside, right over here, and on the right knee, she had congestion right out here. And you can palpate it. Now the next thing I do is I examine for instability. I do this on all patients. Now, in this particular patient, when I examined her, the right knee was showed a partial, and on an MRI, a partial tear. The right knee was completely ACL normal, as Ana's is. You just push up like this, and if there's any instability, this lower bone right over here would just move forward. And it's a very pronounced movement that you can detect. When I did it on the left knee, there was instability. This bone right over here, the tibia, moves forward. And moves forward way too much. So once I get an impression of there's any instability, I double check it once I have the patient laying down, and I'll show you how I did do that. These are typical ACL examinations. They become more sensitive as a practitioner gets more practice, but you have to do 1,000 of them. Alrighty, so once I detected that, I got an idea of where the stress was accumulating on the inside, on the outside, on the inside, on the outside, and a general impression of the instability. So that I got in my head right now as I'm moving forward. Now you're going to lay down, your head over here. Now the next thing I do, this is what gives me the sensitivity, the data on the degeneration. We've gone through this before. I do passive extension of the knee. On a knee that's under duress or it's under a degenerative strain, this motion, this extension, this little motion right over here will be compromised. The more involved the knee is, the more she's going to lack, or the more deficient it's going to show in the knee extension. And that's something that can be seen in most cases when there's a lot of degeneration. Or, as in this case, where it was only 3 degrees, it's a very subtle sensation or deficiency that you only acquire once you do it a few thousand times. Now, in the case that we discussed, There was deficiency on the right, but the left knee was completely normal extension. Now, just to make sure that what I'm sensing passively is true actively, I have the patient push down. Empuja para abajo contra mí, para abajo. I have the patient push down. Relájame. Again, I do it multiple times. If I don't get a true feel, relax. Relájame. I do it individually on each knee. I do it both. I keep going from one knee to the other until I get an exact data. In most cases, I only have to do it a few times because I work with a lot of involved joints. But in this case, since the difference is only -3 degrees, it's a very subtle sensation. And in this case, she was lacking 3 degrees on the right, but the left was normal. That's why I knew, before I even saw the x-ray, that the right knee was under greater duress than the left was. Now, I know that the left knee on the general ACL test was somewhat unstable, but I want to verify that. So the way that I verify that is I do this. Again, these are standard ACLs testing. Relájame. You hold here, grab here, the bottom of the knee, and then you just jerk it up. If there are any strands of ACL intact, you will get a clicking sensation. You literally feel a click. It suddenly stops. This is how I knew that the left knee was not, the ACL was not totally torn, because I got that click on the left knee. The only reason that the MRI of that left knee came back as completely torn is because this patient, as in most patients that are not knee, that ACL gets stretched, and when it gets stretched, it adapts to that stretching, that stress, that stretching strain. So the state, the molecules, the structure of the ACL itself changes. So when they do the MRI is sensitive to a particular element inside human tissue. When that element, or there's scarring, or there's a disruption in the fibers, the way that they are, the way that they are aligned, the MRI interprets it as a tear, and it describes it as such, as a tear. The radiologists, when they see it, they'll describe it as a tear. So if they would have gone in and they would have done an ACL reconstruction on this left knee, when that surgeon went in there, he would have seen that that ACL was not completely torn. But that wouldn't have stopped him. He still would have replaced that ACL, because he was in there already. So they would have replaced an ACL that, if you change the environment of that knee, that ACL can reconstitute itself. But you gotta change the environment upon which is acting on the ACL itself, or on the tissue itself. You change the environment, and then the tissues will adapt accordingly. And she would have regained stability in that left knee by changing the environment. And in this case, in the case that we discussed, the only thing that needed to be done for that left knee is get that patient a smart brace. That's all she needed to do, that she would wear on within a particular protocol that was described to her. The right knee would be treated as if it's under a arthritic state, which is basically what we're doing. So in essence, in this case, unless the practitioner is thinking and has these biometrics and is able to objectify or concur with the reality of what's going on in the knee, with physical examination and objectification of the knee, they would treat both knees as if both of them are under an ACL tear condition, and treat accordingly, when in reality what that patient had was, she has arthritis of the right knee just beginning, and she had an instability of the left knee from a stretched or a sprained ACL. Both knees, same human being, but treated differently. And the only way, and the only way that you can come to that conclusion is if you, the examiner, has a protocol, a program that they can implement to objectify the findings, to use mathematics as a way to better describe, define the reality of what's going on in the patient's joints. Because the idea is, if you do not objectify, if you cannot bring some mathematics to the evaluation process, you're basically guessing. And guessing based on extremely biased past history experience. So again, anybody who watches this video, if you have any questions, feel free to give us a call. You can write to us. If you're in South Florida, if you want a real physical examination, one that will give you the data that you need in order to implement strategies in your life that can change the state of your joint, you just contact us. There's always a phone number there. Again, anybody who watches this video, to everybody, those who love us and those who hate us, everybody, we love you. Until next time.